Hello, welcome to this session on the Dentanomic Surgical Extraction Simulators. We're going to be running through a short course using this simulator to demonstrate single root, double root and triple root extractions. You're going to see me using a range of other equipment during this session. So from a safety point of view, disposable gloves. I've got a stab-proof glove here which is quite useful for protecting your non-working hand, particularly if you're not so confident with dentistry. It means that if you slip, you're much less likely to stab yourself and do damage. And obviously a face mask, as you would wear for normal dentistry. This course is appropriate for veterinary surgeons and veterinary students. You're going to see me using monofilament suture material, scalpel handle and blade. I would suggest a number 15 or number 11 scalpel blade, curette, needle holders, forceps. These are little DeBakey forceps which I find very useful for gingival surgery, and then various scissors for cutting gingiva. You'll need a set of extraction instruments. I've got my Dentanomic set here, so that's elevation and luxation instruments and periosteal instruments for lifting gingiva, and then a normal high-speed dental unit. So it's got a high-speed unit with a variety of burrs on there, round burr, taper cut Fisher burr, and a diamond burr for smoothing bone. The diamond burr is not vital, but it's certainly useful. Let's open up the box and I'll show you what's inside. So you may have a different version of this. We have this double pack with both a maxilla and mandible, and we also have single packs with either a maxilla or a mandible in. So we'll remove that. Take this little cap off the tripod, that's just there to protect it, and take either the maxilla or the mandible, screw it on top like that, and then I will normally undo this little lever here about halfway, so it gives a little bit of mobility to the jaw, and then when you're holding it you can replicate the feel of a normal surgery. So that's how we will set that up, and then we're going to sit down with you and go through incisor extraction to begin with, working back into the mouth. So we're going to start these extractions with a 402 extraction. We're going to make that a simple non-surgical extraction, as if this was a nice loose incisor. So the first thing we're going to do, even though it's a theoretically non-surgical extraction, we're still going to loosen this gingiva into an envelope flap so that we can examine the gingival sulcus, the bone. That's going to give us better access for extraction. So I've got a number 15 blade here on my scalpel handle. I'm going to cut down vertically around the gingival sulcus and across to one side. And I'm going to use a periosteal elevator to lift and loosen that gingiva away from the bone. We've got, that is our Dentanomic periosteal elevator. You're going to introduce that down into the sulcus at an angle towards the bone, and then walk it forwards in this sideways motion, and that peels the periosteum from the surface of the bone. Can you see that here we've got a little bit of attachment there between the teeth that I didn't quite get to with my scalpel blade? In that situation, I can use my small iris scissors, just to sever that attachment, and that's a useful trick. So if you see a small piece of tissue that you haven't quite got to, use nice, thin, sharp iris scissors to sever it. We're going to put the curved side of the elevator onto the tooth. We're going to use the sharp edge of the elevator to find the ligament space. So that's me in there. I'm going to make one small turn, and then I'm going to wait and hold that rotation. Now that's important. That lets the ligament fibers adjust to the movement. You want to be moving these teeth slowly, not quickly, and you definitely do not want to be doing this with your elevators. So always into that space, single turn, wait. Now we're stretching ligament fibres, and then I'm going to repeat that process around the circumference of the tooth. So there's a little bit of mobility now. Each time you wait, you want to be holding that movement for around about 10 to 15 seconds. Now, you can see right now we don't have a huge amount of movement on that tooth yet. In clinic, this is when I would switch to luxation to support elevation. So a luxating instrument is thinner, it's sharper. Going to lift back our gingival flap so we can see what we're doing. Finger on the end, flat part of the blade towards the tooth. You're going to slide that into the periodontal ligament, and you're going to work the blade sideways to the tooth. So can you see that I'm not twisting this blade? I'm just rocking it down alongside the tooth surface itself. And again, I'm going to repeat that around the circumference of the tooth. Now we need to be quite delicate with these incisors. When we've made this model, we've made these incisor roots really quite fragile. So if you try to put too much force in or go too quickly, you will break them. If you break them, you're going to need to go for a surgical approach, which we're going to cover on a canine extraction in a moment. You can see I'm switching back to elevation now, so I'm going into the same space I've just luxated. I'm turning the blade and I'm waiting for the ligament to react to what I'm doing, to stretch and adapt. Giving that 10 to 15 seconds, and then I'll try a little bit more turn, but I'm not rocking that blade backwards and forwards. I'm putting it into the space, leaving it and waiting. And typically I'm going to go back to a luxating movement. And cut around the tooth, repeating the same movement. All the way around. You need to be careful to make sure that you are actually putting the blade down the correct piece of periodontal ligament and you haven't accidentally shifted over to the tooth next door. And you can see now that as I'm working, we're beginning to get a little bit of mobility on that tooth. The tooth is beginning to rise. So as you push the blade further down, the mechanics of the tooth movement will lift the tooth further up. And generally, I don't use dental forceps very often at all. I tend to use my fingertips mainly. You should be able to get the tooth loose enough with your surgical instruments that you don't need to use a lot of force on dental forceps. So that's got us a nice clean extraction. Now we are going to radiograph that. We are going to check to make sure that we have got the entire root and we haven't left a fragment down in that socket. Next stage, we want to curette out any infected material. So if we've got granulation tissue in there, if we've got infection around the gingival sulcus, we want to get rid of that before we close, because that's all material that's going to contribute towards infection. So I will curette out that space. I'll give it a gentle flush with some sterile saline, and then I've got a socket that's ready to close. In some cases, if I've got a jagged edge of bone there, I might be smoothing that bone edge off, and then we can very gently smooth some of that bone. The next thing we're going to do is use our periosteal elevator to free up space on the other side of the socket so we've got more mobility in this tissue. So I'm going to put my finger on the end, and then I'm just going to use that periosteal elevator in a sideways motion, same as we were doing before, just to lift that away. So we're taking monofilament suture material. I tend to use a reverse cutting or round-bodied needle, gripping it near the end of your needle holders, finger on the hinge point for control. I'm using my atraumatic forceps to lift the gingiva, and you want to take a bite about 2 millimeters in, rotating your wrist like this, and then again on the other side. And if you rotate your wrist like that, you'll find that the needle will bite through the tissue cleanly. Now you can see in this case we've got quite a lot of movement in the gingival tissue. I don't need to do a periosteal release here because I can close those sides together with minimal tension. What we're going to do on some of the later extractions is to do a periosteal releasing incision on the inside of this flap. That's going to give us more tissue mobility. But in this case I can do 1 or 2 simple interrupted sutures. That would be my preference. Lifting to settle the knot down same as normal, and then just closing that gently with minimal tension. And that's it. So in clinical use I would probably put another suture next to it. You want to take bites of around about 2 or 3 millimeters into the tissue, and I would space those sutures 2 or 3 millimeters apart to get myself a nice strong flap. Reasonably short ends so that your sutures are not getting in the way. Okay, let's cut. So now we've done our simple incisor extraction, we'll move on to a more complex surgical extraction, still on a single rooted tooth. Here I've picked this maxillary canine. You could apply the same technique to more or less any single rooted tooth. Don't forget that there are some anatomical features that we're not going to touch on in this simple video, but you've got maxillary mandibular arteries, you've got the sinus up here next to this long maxillary canine root, so you do have to be aware of some of the structures around you. But what we're doing here is focusing on the surgical technique itself. So imagine here we've got perhaps a fractured maxillary canine that we need to extract. We've radiographed this first so we know what we're getting into, and we're going to construct a gingival flap so that we can lift gingiva away from the bone. And to help us with this extraction, we're going to remove a significant piece of bone overlying the lateral aspect of the tooth root. That's going to make it much easier to extract the tooth and allow us to use less force. So in order to construct that flap, we are going to cut into the gingival sulcus. Here you can see I'm using a number 15 blade. You could use a number 11 as well, or some of the specialist dental blades. And we're going to cut down into the gingival sulcus around the full circumference of the tooth. And that's taking away quite a large part of the strength of the periodontal ligament before we've even started to use our extraction tools. I'm going to do a more complex pedicle flap here so that I've got more access to the bone. So I'm not just going to do an envelope flap where I lift that gingiva away and then try and work through that space. That won't give me enough access. So I'm going to cut horizontally down onto the bone this way, and again this way. Now what that means is that it's taking our suture line away from the area that we're going to be removing bone. That means that our suture line is supported by hard tissue, which means that there's a lower chance of our flap breaking down. You want your flap to have a wider base than the top, and that means that you've got more vasculature coming in here and a higher chance of healing. So I'm going to make incisions there over the bone, and then I'm going to lift that gingival flap away from the bone using my periosteal elevator, same as before. This is a 4mm elevating blade, which is probably about right to start off with, but I may want to switch to a larger or smaller one depending on where we get to. So placing that down into the area that I've cut, putting the edge onto the bone, and then I'm going to work that sideways along the bone in order to clear the periosteum off the surface of the bone. Can you see my index finger is resting quite firmly onto the tissue there, and that stops me slipping. And just work your way around the tissue like this and find the edges of the cuts that you've made to start to free those up as well. This will normally take you a few minutes. Just be delicate with the tissue so that you don't accidentally punch through it. Now, I'm then going to take that flap, just put my thumb over it to protect it and to bring it back, put some tension on there, and as you put some tension onto that tissue, you're going to help to free up the rest of it. Quite commonly, you will need to use your scissors just at these corners to free up that tissue. And you can see how much advantage that gives you to put a little bit of tension onto the tissue to retract it as you're working. So we've got ourselves a nice gingival flap there. Okay, what we're going to do now, double check our radiograph, make sure there's no structures in the way. We're going to remove a small section of bone overlying the tooth root. The better you get at extraction, the less bone you have to take. The very good people can do these extractions without removing bone, but in most cases I will remove a section of bone up to about between 1/3 and 2/3 of the height of the tooth root. In this case, we're going to go around about 1/3 of the height of the tooth root, and we're going to lift a square of bone away. I'm going to use a round burr on my high-speed drill. You can either palm grip it like this or pencil grip it like this. As long as you've got your fingers towards the end so that you're stabilizing the instrument. The only thing you don't want to be doing is holding it with your hand a long way away from the working end. And I'm going to run this parallel to the tooth so the round piece of the burr is coming down and over the bone. Just to stop there for a moment, what you can begin to see is the colour change. So as we're getting closer to the periodontal ligament, you're going to see the colour of the bone adjust. What I tend to do is I'll rough out the shape first that I want to remove, and then I'll go back and tidy it up afterwards. So now we've got a good bit of root exposed. The next thing that's quite useful, if you have any bits remaining on this canine, if it's not completely fractured, I will normally take a Fisher cut straight side cutting burr and just remove that bit of crown, because that's going to get in my way when I'm using my instruments in a moment. Gentle pressure. So now we can access the ligament tissue all the way around the tooth. We've removed quite a lot of strength from that tooth already. Going to put the edge of that elevation blade onto the tooth. I'm going to let the tooth guide me into the ligament space. So a gentle push to make sure I'm in the right place, a small turn, and then I'm going to wait. And notice that my index finger is towards the end of the blade, resting on the tissue, so that if I slip, I don't do too much damage. Always turn and wait and hold that movement. That allows the ligament to adjust to what you're doing. It will stretch, but only if you give it time. And on a big tooth like this, I might give it 20, 30 seconds or even longer for that ligament to adapt. The more tissue you're trying to stretch, the longer you leave it. Now you can see that I'm beginning to slip out of that space. So I'm going to give up on that part. I'm going to move to the other side. I'm going to repeat the same process. Gentle turn, wait, 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 wait. And I tap my foot and I count seconds to make myself wait long enough. Again, with elevation, it's very important not to use these rapid rotating movements. That will slow you down, it will damage your instruments, and it's much more likely to break your roots. So always in and turn one way or the other way. Okay, so I've got a tiny little bit of movement there. You could see that from the elevation. I'm now going to get a luxating instrument and cut into the space that I've just loosened with the elevation tool. It's good. So I'm going to work into the space. Notice the blade is pointing directly down into the periodontal ligament space. I'm going to work it in that sideways movement. My finger being on the end there means that if I slip like that, I can't do any damage. So working it down and cutting down into that space. And then repeating that process, you can see we're beginning to get a bit of tooth mobility here. Don't get overexcited, just keep that same gentle movement going. And you want to repeat that movement on all aspects of the tooth. If this is an old dog and that tooth is ankylosed, it's going to take you longer than this to free that tissue up because it's a smaller, tighter space with less soft tissue. Don't forget to use these areas where you've removed some bone. Those areas will allow you to access the periodontal ligament, and you can cut down in there. And then when your luxation has worked and you feel like you've got good access, you can put it down, go back to elevation, into the space, turn, and you can see we've got a little bit more tooth movement there. We're going to maintain that pressure. Let the ligament adapt. Give it another few seconds. And then you can try a little bit more turn. My blade's skidding out of that space, so I'm going to turn, go around, find myself a new place, put a little bit of pressure on, leave it and hold. Bit more movement, which is great, and then we repeat the process. So go back into that space with a luxating instrument, cut down, work your way around, always remembering, key point with all instruments, not just these instruments, fingers got to be near the end of the blade because you will slip in all cases, and this hold means that when you slip you don't do anything bad. And you can see that I've got the blade rocking sideways to the tooth. Can you see that in luxation you don't twist, you rock side to side, and it's a very efficient movement. Elevate again, and we should now be getting a little bit more, there we go, a little bit more mobility of that tooth. So as we turn the blade, the tooth lifts. That's why they're called elevators. And we just repeat that process. There we go. Now, as we go further down the tooth root, it's very useful to switch to a smaller instrument. So you need to match the instrument size to the tooth root size. So this blade is now getting a little bit big for this tooth. So I'm going to switch out and go down a size. Again, into the space, turn and wait, and that's giving us more tooth mobility, which is very useful, but still the same technique. Turn and wait. And that's tearing those fibres. So if you're struggling with instruments, try either switching between elevation and luxation, and try switching between bigger instruments and smaller instruments. And these models are great to practice that on. So we're getting now down to the lower parts of that root. Not wanting to use dental forceps on this. So until you can actually extract that tooth with your finger, that's when it's loose enough to remove. Okay, again, we're going to radiograph and we're going to make sure that we've actually extracted the entire root and we haven't got ourselves a fractured tip down at the bottom. If we were to have fractured that tooth root, what we're going to do is extend our area of bone removal down until you can see the end of the fractured fragment, and then we're going to use elevation and luxation again to lift those free. Okay, so cleaning out the socket is going to be the same as before. We want to curette out infected granulation tissue so that we create a healthy, clean socket. We're going to flush that with sterile saline. Most people do not recommend using strong disinfectants or hydrogen peroxide or anything like that. Curetting and debriding properly and then using sterile saline to flush seems to work very well. So remove any loose fragments of tissue, and then we're going to use our diamond burr to smooth off around the edges before we extract. You could hear before when we were doing the main extraction a little crack. That was a piece of the overlying bone breaking, so I've removed that fragment. We don't want that in our wound. And we'll just smooth off that part that it's come from. That. Now we're going to perform periosteal elevation on this piece of gingiva. Some people will elevate this part before they start the extraction. I find it very difficult to get to, so I like to extract the tooth, improve the access, and then loosen up that piece of tissue. On the inside of your gingival tissue, you now have a sheet of periosteum that you lifted from the bone. Gingiva will stretch very nicely, periosteum does not. There are two ways to create a periosteal releasing incision. If you are very careful, you can gently use a scalpel blade to create a horizontal cut in that layer of fibrous tissue. The danger with that, particularly in cats, is that you can go all the way through your flap without realizing. It's generally safer to use iris scissors to blunt dissect that fibre free from the gingival tissue. Like that. So you want to do a horizontal line all the way across your flap. And you should begin to see those fibres separating out. You can see some of them there. And again, you're wanting to place 2 or 3 millimeters bites in and place your sutures about 2 to 3 millimeters apart, using a nice wrist rotation to bring that curved needle through. And you should be able to close those edges down without tension. If you place your sutures over unsupported tissue or you place your sutures under tension, they will break down just like a skin incision would. Number of throws depending on the suture material that you're using, same as skin surgery. And essentially I would just repeat the same thing all the way around my flap. Generally I place sutures kind of here and here, and then I fill in round the edges to spread the tension nicely over the entire piece of tissue. Let's talk through a 2-rooted premolar extraction. So again, radiograph first, make sure that you know what you're getting into. You can incidentally radiograph these models if you want to, or you can just refer to the graphic that we've supplied with these videos showing you the location and anatomy of these roots. So we're going to do a surgical approach to this premolar. Again, we're going to take our scalpel blade, we're going to cut down into that gingival sulcus, going around the entire circumference of the tooth. Now we are going to make a pedicle flap for this approach because I want to lift that gingiva back. If we wanted to do an envelope flap where we don't make any releasing incisions down here, then I could just make this a larger flap, so I could cut horizontally from here all the way around this tooth and all the way around this tooth to lift a larger component of gingiva back. But in this case, I've gone around the circumference of the tooth and I'm going to make 2 incisions here and here, being careful to place those over the bone so that I'm placing my sutures onto supported tissue. Again, I'm going to use a periosteal elevator now to lift that piece of gingiva free, working my hand flat. So you see this flat rocking motion, so I can walk the instrument along the bone. Not too much pressure, just let your sharp instrument do the work. If you're finding that periosteal elevation is too difficult, it's because your instruments aren't sharp enough and they're trying to tear through tissue rather than cut through tissue. And again, I would normally use my thumb like this just to gently retract that tissue while I'm working on the flap. And then during the extraction itself, I'm either going to hold it out of the way with my free hand, or I'm going to put stay sutures or a pair of forceps onto that tissue, stay sutures being the most delicate. Okay, So now what we're going to do is remove a small amount of bone overlying the tooth roots, and then we're going to section this multi-rooted tooth into 2 single-rooted fragments. We're going to start from the bifurcation here, and we're going to make one cut going out about 45 degrees this way and one cut going this way. And what that does is it gets the majority of the crown out, and it gives me really good access to my elevation and luxation instruments. So I'm going to switch burrs from a straight cutting to a round burr, and then I can remove bone, probably aiming to remove bone over around about 1/3 of the height of the tooth root to begin with. If you're concerned about your fingers being too close to the drill, then you can use forceps just to keep that flap retracted. So we're going to take elevation and luxation, and we're going to work around the circumference of each one of these tooth roots and take them out as if they were 2 single-rooted teeth. Being careful not to use the adjacent teeth as leverage, because you don't want to be damaging the teeth that you're leaving in. So find that ligament space, make a turn, hold that turn, stretch the ligament. And make sure that you're giving enough time for that ligament tissue to adjust. And then you repeat that. Now I'm going to switch to luxation because we were getting a little bit of movement before. So finger towards the end, find the ligament space, gently cut down. You can see we've got a little bit of tooth movement there. So we have a little bit of movement now in this tooth root. We're going to luxate. So thin edge into that space. And just gently cut around the circumference of the tooth And then back to our elevating instrument. If I was struggling here, I would be switching down to a smaller blade, but you can see that that tooth is beginning to free. So then I can lift that root out. Same here. So personally, I tend to start with a little bit of elevation. Find that space, small amount of movement, wait. Let the ligament adapt. Tie a little bit more. And then we're going to repeat that around the circumference of the tooth. And just a small turn with the elevator. If you try and make the tooth move too much too fast, you are far more likely to snap it. Again, I'm going to move around. I'm going to try and move the tooth back the other way. And you saw that blade edge find the ligament nicely there. And even though I've got a fair amount of tooth movement, I'm not trying to make it work too fast. I'm just giving that ligament time to adjust. and adapt. That's about as much movement as I'm going to get. And then back to luxation, and you can see as I luxate, that tooth will begin to lift free. Minimal work with the forceps again. Now if you have to use forceps, and the same goes between something like thin forceps like this or proper dental forceps, if you were going to use them, you use them as if you were using an elevating instrument. So you're going to grab the tooth, you're going to make one small rotation, you're going to hold that rotation. You definitely never use forceps in this fashion. You're far more likely to break things. So if you're going to use them, grab the root, gently make a turn, hold that turn, let that soft tissue adapt to what you're doing, and then make another turn one way or the other, but never wiggle. As you curette out your infected granulation tissue, you're going to get some bleeding. Good granulation happens into tissue with a blood clot in it. What you don't want to do is scrape this space out, dry it with your air syringe, and leave a completely dry socket. That's painful, and it will take much longer to heal if it ever does. I'm going to smooth my bone edges after I've curetted. Across our flap, and as I said before, my preference will be blunt dissection with iris scissors rather than using a blade to do that. And then you should find that you can advance the gingiva forwards with minimal tension. And then you're going to place your simple interrupted sutures around about 2 to 3 millimeter bites of tissue and about 2 to 3 millimeters apart, as we did before. In this situation, you can just see that little extra bit of tissue there. I would just remove that. Trim those edges so that they're neat and you've got no bits of weak tissue that could give you breakdown problems later on. So 3-rooted extraction on this 108. Thing that we have to think about when we're designing our flap, we do have salivary ducts transiting across this tissue here, and you want to be a little bit cautious about making a pedicle flap cutting this way, because you might accidentally sever a duct. Now there are ways to get around that, but this is one useful method that I tend to use in general practice. So what we're going to do is go around our gingival sulcus same as normal, and then we're going to make one releasing incision this way to make a triangular flap that we can then flap back. That should give us enough access without worrying about salivary ducts here. So same as before, we're going to cut down hard into our gingival sulcus. All the way around, and then we're going to extend that horizontally a short distance so that we stay away from the area of bone that we're going to remove, and extend that down into a releasing incision. Now, as I say, there are multiple ways to work on this tooth. This is just one method, but it's a sensible method that works very well. We're going to use the same periosteal elevation technique, so pressing the blade down onto the bone to make sure that we're splitting periosteum from bone and not periosteum from gingiva. In a moment, what we're going to do is section this 3-rooted tooth into 3 single root fragments, and then take each one of those out individually. You can see there again we've got a little bit of tissue that I've missed, and you can use our scissors just to snip that free. And another little piece there. Okay, so now we can see our bifurcation. We've got 2 roots here, one just under there, and 1 root there. And always, always, always radiograph so you know what you're getting into before you start. Now we've sectioned the teeth, we've got 2 roots here and 1 root here. We're going to work on this root. Same principle as before. Find that periodontal ligament space, apply a small amount of turn with our elevator. And just wait. Allow that tissue to adapt to what you're doing. Now you may find here that this little bulge interferes with the ability to get an elevator into that space. If it does, then you can section, but be very careful that you don't touch the tooth behind it. So that gives me better access now into that ligament space. So I can make a small turn with my elevator and just hold some pressure. This is when I'm finding that I'm starting to struggle with elevation, I will switch quite quickly to luxation. Elevation and luxation are quite complementary techniques, and you could see that that luxating blade penetrated down into the ligament space much more effectively than the elevator was doing. So we're going to use that sideways rocking motion to cut the soft tissue. We've got a good amount of mobility now on this tooth root, but I'm still going to use my extraction instruments to do the last part of the extraction rather than my dental forceps. Just lifting some more of the gingiva away from the bone so that I can see what I'm doing. So we've now got a little separation between those two roots. I've got a tiny bit of mobility when I put an elevating instrument between them. So now we're going to apply the same principles as we applied before, elevation and luxation, working around those roots. If I find that I'm struggling, I have lifted enough gingiva that I could extend my area of bone removal down further. Again, as before, I'm switching between elevation and luxation, using the luxating instrument to cut into that space with that nice rocking motion. And I'm keeping my fingers quite relaxed. I'm using the heel of my hand on the instrument to encourage it down. And I'm keeping my fingers light and gentle, which allows that thin edge to find and follow the ligament. Always palm gripping, never having the end of the instrument hovering in midair. You always want your fingers as close as possible resting on the tissue. And you can see we're getting some nice mobility now. See the length of that root. That's why you need to be careful and delicate when you're extracting. Okay, now we have our last root here. This is often the one that people struggle with. The secret to this, certainly in my hands in general practice, I will now remove a small window of bone here from that central piece of bone that used to be in between those two tooth roots. And that gives us the space that we need to lift that tooth out carefully and surgically. So I'm switching again to a round burr. This is a difficult route to work around, so just be gentle. Let the thin edge of the blade find the ligament space, and then a small amount of turn. Although this is a short route, it's a very delicate route and it's quite easy to fracture it by accident. So just be delicate and use the instruments the way they were designed. Get the instrument into the space, let the blade do the work. Definitely here, I will always do this combination of elevation and luxation. Means more precision, less force, which is always good. And there you have, do you see again, that's a very thin, delicate root, very easy to fracture if you use too much power. Really. We're now going to do what we did before and make a periosteal releasing incision. And you can see why it's so important to smooth off these edges before you start placing your sutures. Otherwise you're pulling that tissue down across a sharp edge, much more likely to punch through. So again, as before, bites 2 to 3 millimeters deep and 2 to 3 millimeters apart in order to get nice strong sutures.